All right, guys, let's go ahead and turn our screens on. We'll get class started. How's everybody feeling after exam two? Ready to learn more, I am sure. Okay, we don't have too much time left in class, a little under an hour left. So let's go ahead. I'm going to pull up Canvas here. We're going to go through a couple things as far as assignments, get into our class PowerPoint following that. All right. So as far as week 7 goes, here is what you guys have due this week. You have your discussion number 3, which is due, your initial response is due tonight by midnight. We have our teaching plan, which I'm going to go over that with you guys in more detail. And then we have the SimChart external cephalic version assignment. Okay. The discussion, you have to reply to 2 of your peers by Sunday. The other 2 items are due by Sunday as well. Okay. Let's go into our teaching plan here. I want to go through that in a little bit more detail for us. Okay, so when you open the assignment, it gives you really awesome detailed instructions on how to complete it and what we're looking for, but we're going to go through it all together. So you guys are going to need to document a full head to toe on a preterm neonate, focusing on both normal and abnormal findings. Okay, so you need to only identify at least 2 abnormal findings as we're developing our teaching plan. Okay, so what is this going to look like? So typically, what students have done in the past is they will put a full head to toe newborn assessment, like what a normal is, and then they'll either highlight or bold or put in a different color an abnormal finding. Okay. At the bottom of the assessment, they'll then write abnormal findings noted on assessment and write those there again. Okay. So I'm not going to be giving you an head to toe assessment. This is something that you guys are going to need to get from your textbook or other resources to put into your PowerPoint or your presentation. Okay, so once you have your assessment put in and you have those 2 abnormal findings, then typically students in the past have devoted a specific slide to each of these 6 individual points. Okay, so you're going to need to go through safety concerns for preterm newborn, symptoms to report to the pediatrician, follow-up appointments, skincare and feeding, infection control, and then community resources and support groups. Okay. I am not going through this with a fine-tooth comb, meaning like my goal in life is not to give you a 0 on your teaching plan. I would like to give everybody 12 out of 12s. So what I do is I go through your PowerPoint assessments. I read your assessment. If you have everything in there, awesome. Moving on. If you have your 2 abnormal findings that I can see very clearly, awesome. Moving on. And then if you have these 6 points here included in your presentation, awesome. 12 out of 12. Okay. This is not supposed to be a super lengthy, time consuming assignment. Okay. You should not be spending more than a couple hours on this, if that at all. So you can use a PowerPoint presentation, poster, video, or Word or PDF document. We do want this to be creative. So if you choose to do a Word document, please do not just like type in a bunch of information. Like it should be attention grabbing because it's supposed to be geared towards families, right? It's supposed to be a teaching plan for families bringing home a preterm newborn. So we need it to be like somewhat entertaining or, educational. Okay. um, for those of you who are repeating the course, please do not resubmit your assignment from whenever you took the course last because we put everything in through a plagiarism tool. And I've had it before where a student who's repeated the course has had it flagged and marked as like plagiarized. And then we have to like have you meet with me and explain why you got that grade and why it flagged it. So just for the purposes of this assignment, you're going to have to redo it if you have taken the course already. So then if you scroll down in the assignment, you'll see the rubric here for you on exactly what I'm grading you on, okay? This is 1% of your overall course grade. Um, so definitely you should submit it because 1% is a difference sometimes between a pass or a fail. So definitely be doing this assignment and submitting it on time, okay? If you have any questions at all, please email me about them. Does anyone have any questions right now that they can think of? Okay, awesome. So let's go back in here. So then week 7, we just went over what we're doing this week, what's due. If my computer will listen, there we go. Week 8, you guys will have another quiz at the beginning of class, okay? So make sure you're in class on time next week. We're going to do our last quiz um, at the start of class, okay? Next week is also going to be when we're posting all of the exam review sessions. So if you guys want to go to an exam review for a week for exam number 3, those are all going to be taking place next week. Okay, you're going to get a schedule about that at the end of this week with all the professors' different times that they're going to be holding those sessions. Okay, then we're already taking exam 3 in week 9, which is just absolutely crazy. This flies by really fast, guys. So we'll go through and do some review next week as well, hopefully at the end of class all together too. Okay. Going back to exam 2, you guys are going to be getting your grades back just like last time this Friday, okay? So it'll be Friday evening or so. We have to meet with all the other professors and decide if we're giving any points back or whatever we're doing. And then I'll post your grades. So if it's not until like 10 p.m. Eastern time, that's usually when our meetings are over. So just be on the lookout for that, okay? Any questions before we get into our PowerPoint for the week? All right. All right, guys. So this week we're covering content on the relating to the newborn. We're going to review like we do every week. What would be signs of chorioamnionitis?
Tachycardia.
Fetal tachycardia,
Fetal tachycardia. What other things would we see?
maternal fever,
Yep, mom will have a fever. What's our fluid going to look like?
Past field and with an odor.
Yep, that's going to smell weird. And it's usually like a yellow or purulent color. So you guys got it. Maternal and fetal tachycardia, yellow, purulent, or odorous fluid. And then another one is abdominal pain and tenderness and a fever. So when we think about like this is an infection, right? So what are our normal signs and symptoms of infection? Fever, swelling, redness, tenderness. So that all applies here. It's just uterine, okay? So that abdominal pain and tenderness is coming from the uterus being tender with that infection, okay? What should be considered to give to a woman in preterm labor, and what is the purpose of this? What medication?
Betamethasone.
Betamethasone. Yeah, what is that?
It's for the lung development.
Yes, it helps develop fetal surfactant faster. So, betamethasone is administered IM. The mom will get 2 doses 24 hours apart to increase surfactant production in the fetus and hasten fetal lung maturity. So, surfactant is that substance that basically helps the lungs expand easier through the alveoli. With adequate lung expansion, we're seeing adequate CO2 and oxygen exchange, and good oxygenation, okay? Preterm infants do not have fully developed surfactant. So that is why oftentimes with a preterm baby, we see respiratory distress, signs and symptoms of respiratory failure because they don't have that surfactant. So the exchange is being limited because it's harder for them, for their lungs to expand all the way and stay expanded, okay? Typically, we can also administer surfactant once a newborn is delivered. It's usually given via ET tube, but we want to avoid that. So one of the ways we can avoid that is by administering betamethasone in a mom who's in preterm labor or in a mom who we consider to be high risk. So if she's had a preterm baby in the past, their provider may prophylactically administer this medication, specifically if she's being monitored for prolonged amounts of time during her pregnancy, specifically for preterm delivery. What meds are considered tocolytics used to decrease contractility of the uterus, especially with preterm labor?
Sertraline.
Yep. We can give terbutaline.
I forget how to pronounce the other one, but it's like Nipa. There's a starts with an N. There's an I and an F somewhere in there.
Yes, you're on the right track. Nifedipine. Yeah, I think I said it right. Yep, nifedipine. So here are our four. We have indomethacin, nifedipine, magnesium, and terbutaline. Okay, so we know magnesium we typically will give to prevent seizures in preeclamptic patients. However, magnesium is also a relaxant, right? So it can also do the job of relaxing that uterus and preventing as many contractions. That's not the primary reason why we're going to use magnesium, but it also can do that at the same time. Terbutaline is another one that we will give. It's a relaxant that will help decrease uterine contractility and help prevent moms from having too many contractions too early. Which medication has tocolytic properties as well as provides neuroprotection to a preterm neonate?
The magnesium sulfate.
Yeah, magnesium. So magnesium is another thing that we can give. Mag is just awesome. There's so many uses for it, so many reasons why we would give someone this medication. If mom is in preterm labor, not necessarily that we're trying to stop it, if it's going to happen regardless, magnesium is something we give to protect baby's brain. Specifically, it helps protect baby's brain against development of cerebral palsy. Okay, so this is another use for magnesium here. What risk would we associate with post-term patients? So if we have a mom who comes in who's 42 weeks pregnant, what are we worried about with her?
Macrosomia.
Mm-hmm. Yep. We're worried about a big baby. If we have a big baby, what else are we worried about?
Polyhydramnios.
Not necessarily if they're post dates. They might not have more fluid. They'd probably have less fluid, right? What'd you say, Macy? Sorry.
Shoulder dystocia.
Yes, with a big baby, we're worried about shoulder dystocia for sure. Okay, that's definitely something we're going to be concerned about. What else are we worried about with a post-term patient? So let's say like from a anatomy standpoint, what is that mom's placenta going to look like probably if we're overdue? Do we think it's going to be perfusing as well as it would be in a 37-week pregnancy? Probably not. So This is a little bit of extra thinking for you guys, but which I know you don't want after taking an exam. But so if you have a mom who's 42 weeks pregnant, those vessels are going to be continually constricting on the placenta. The placenta is going to get a little bit old, it's going to get tired. It's not going to perfuse as well. So if you have a mom, at least in labor, and you're watching the fetal heart rate tracing, baby might not have as much variability. They may not have as big of accelerations. They may have a little bit more decelerations during their labor. And that's just because the placenta is getting tired and not perfusing as appropriately to that fetus. Okay. So we also have to tell our moms to be doing appropriate kick counts, fetal kick counts, and movement because we want to make sure that that baby is still being well oxygenated, especially if they're that far past their due date. So, meconium stained fluid is something that we are also at a high risk for with post-term patients, with post-AIDS patients. Oligohydramnios, because mom is not going to be producing as much amniotic fluid as quickly and this far into pregnancy. Excuse me. Macrosomia leading to birth injuries and labor dystocia. What are 3 complications to precipitous labor? First off, what's a precipitous labor? What does that mean?
It was a
Fast
quick,
labor.
A very fast labor, yeah, typically under 4 hours. So if we have a really fast delivery, what are some things that we're worried about?
Hemorrhage.
Hemorrhage, definitely, yes.
Boggy uterus.
Lacerations, yes.
The
100%.
boggy uterus.
Yes, the uterus is not going to have great tone. Yeah, you guys got them. So the other things too that we can worry about are placental abruption, a uterine rupture, vulvar hematoma, okay? But yes, we're worried about lacerations, postpartum hemorrhage, and a boggy uterus. And that's because that uterus is working so hard for such a short amount of time that it basically poops out and it's tired, right? It's like any muscle. Anytime you're overusing a muscle, it's going to get tired. It's not going to work as effectively. That's the same with your uterus. If that uterus is delivering a baby in 4 hours from start to finish, it's working overtime. So it's not going to want to stay toned as appropriately after the birth of the baby. What tool do we use to evaluate the inducibility of the cervix?
Is that the scale? Like over 8 is favorable, under 4 you have to give more um, time or medication.
Yes, this is a Bishop score. So a Bishop score is what we use whenever we have a mom who comes in and she's like, I am just so tired of being pregnant. I would like to be induced right now today. Okay. So we perform a vaginal exam and she's 3 centimeters. She's 60% effaced. Baby's head is down. We can feel presenting part. This is probably a favorable cervix for an induction, right? We have a first time mom who comes in. She's 41 weeks. She's doing okay with her pregnancy, no other underlying medical conditions, but we check her cervix and she's closed, thick, high. We can't even feel baby's head. She's probably not going to be a candidate for an induction. Okay, so a Bishop score is basically telling us how successful an induction will be based on the mom's cervical exam, where that baby is in the pelvis, if the baby is in the pelvis yet, and other contributing factors. Okay. For your exam, you guys may need to know how to identify a Bishop score or how to score on a Bishop score. So you need to know what we're looking for when we're doing the Bishop score and how to give an appropriate result. Okay. But yeah, typically anything around like 6 to 8 is favorable, and most providers will induce with that. Do providers do induction still if a mom's cervix is a 1 on the Bishop score? Yes, they do. Okay, and that does not necessarily mean that they are not doing something that they shouldn't be, right? Like you can induce a patient most of the time if they want one for an elective reasoning or for a lot of medical indications. However, I'm sure some of you guys maybe have seen like on Instagram or wherever that women are very afraid of getting inductions anymore. They don't want to be induced because they're scared that they're going to have a C-section and that all inductions lead to C-sections. But what it really is providers not educating their patients on, hey, listen, you don't necessarily have a super favorable cervix. So this induction may not go the way that you want it to. And it also may not just be like patients not understanding or knowing that just because you want an induction doesn't necessarily mean that your body is ready for one, right? So that is that about the bishop score. I would definitely understand that when we go towards exam 3. Okay. What would be an example of a cervical ripening agent?
The progesterone gel.
Yep. So what would we call a ripening agent, like a cervical ripening agent, like the category of medication?
I don't want to be wrong, but prostaglandin?
Yeah, prostaglandins. Excellent. So our prostaglandins are our Cervidil, misoprostol, and prostaglandin gel. Where else have we seen this medication? Misoprostol. What's the other name for misoprostol? Does anyone remember? The other name for this medication is Cytotec. Misoprostol is a medication that we give during labor to induce labor as a cervical ripening agent, but it's also a medication that we'll give postpartum to prevent postpartum hemorrhage. Okay, so oxytocin and Cytotec are the two medications that we're going to give on labor and delivery that can be given both to induce or augment a patient and also to prevent postpartum hemorrhage. It all just depends on the dosage of the medication, okay? So if we're having an induction and a mom's coming in to be induced, we're only going to give her 0.25 micrograms of Cytotec. Typically, it's placed vaginally up by their cervix. In a postpartum patient who's having excessive amounts of bleeding, we're going to increase that dose to 1,000 micrograms. Same with Pitocin. So you guys know like your dose of her Pitocin during labor is about 2 milliunits per hour. So that's typically only like 6 mLs. Okay. Um, so very, 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 very small dosage. For postpartum, we're giving that medication as a bolus. Okay, so it all just depends on what stage they are in, but misoprostol is used for both a cervical ripening agent and then postpartum to prevent us from bleeding too much. Name 2 common maneuvers used to resolve a shoulder dystocia.
The Gaskin.
Uh-huh, yeah. There's so that should probably say 3 because that is correct because that's your hands and knees position.
I know the McRoberts.
McRoberts, And then the last one is just suprapubic pressure. Can someone walk me through, like, what would it look like? How would we do the McRoberts maneuver?
You would put their feet behind, pull them up behind their head, or at least kind of close to that area, and then also do the suprapubic pressure.
Yeah, so the McRoberts and the suprapubic pressure are typically done in tandem. So what happens is you have a nurse on one side, a nurse on the other side, your provider is down trying to deliver the head, and then you have a third nurse who's applying suprapubic pressure standing on a stool. The two nurses on the side of mom are going to pull her legs out first, so completely extend them, and then bring those legs back as far or as close to the mom's chest as possible. Okay. That motion and that movement of the pelvic bone is going to help to relieve that anterior shoulder that's stuck under mom's pubic bone. Okay. And then that third nurse is applying that suprapubic pressure to help release it as well. What's an important consideration when prioritizing care for a cord prolapse? What is our number one priority in a cord prolapse? Who are we worried about in the cord prolapse? Are we worried about mom or are we worried about baby?
Baby.
Baby. So our prioritization for a cord prolapse is fetal oxygenation. We need to make sure that baby is being well oxygenated. What are our interventions for a cord prolapse?
Knee to chest position.
Yep, knee to chest. Why that position specifically? What is our goal with this intervention?
To help remove some of the pressure onto it.
Yeah, we're trying to get pressure off of that umbilical cord. So that's why we're putting not baby, we're putting mom in that knees to chest position to try and relieve some pressure of the presenting part off of the umbilical cord. What else are we going to do for a cord prolapse? Is this patient going to deliver vaginally? No, she's a stat C-section immediately. We need to get that patient back to the OR. What else would we do in the meantime while we're getting her back to the OR? What are some things that we can do to help relieve pressure on this umbilical cord and oxygenate our baby?
Oxygenate mom.
Yeah, oxygenate mom. We're going to put a mask on her for sure. We're doing our normal interventions that we would if baby was having late decelerations. We're going to give mom a fluid bolus. We're going to administer oxygen. We already are changing her position. The other thing with cord prolapse is nurse is going to have sterile gloves, and they're going to perform a vaginal exam, and then lift that presenting part physically up off of the umbilical cord. Okay. They're also going to have to try and get fetal heart tones as they're getting wheeled back or as we're trying to transition back to the OR. Okay.
So, out of all of those, what is the first priority or the most important out of those?
Putting mom in a knee to chest position, because that is going to immediately try get some pressure off that cord and oxygenate your baby. The other ones are good, and then the next thing, we obviously want our provider at the bedside, right? And then we need to do a section ASAP. All right, so let's move on to some content for this week. We are not going to make it through the entirety of this PowerPoint tonight. So anything that we will not get to, we will finish on week 8 and then do our week 8 PowerPoint, okay? So here's our scenario. You are called to a delivery to take care of the baby. The baby is not yet delivered. What might you, as the baby's nurse, want to know before delivery in order to best prepare for this baby? What are some questions that you're going to ask the labor nurse?
What medications the mom received during leading up to that point?
Yeah, that's a great one. Has she received any pain meds? Because why would we want to know that?
that could affect the baby once it's born.
Excellent. Yeah, we could see some respiratory depression with our newborn. Oh, I accidentally clicked ahead. I gave you that guy, you guys that one. Gestational age. We want to know, is this baby term? Are they post dates? Are they preterm? What are we looking at here? What else would we want to know? What other things can affect our baby when they're delivered or how they do after delivery?
Like any history on the mom? Like, is there any history of diabetes, hypertension,
Yes,
drug use?
yes, definitely. Mom's history for sure. What about like fluid? We probably want to know the color of the fluid, right? If mom had like really thick meconium fluid, we're going to probably anticipate doing some more resuscitative measures with this baby. Okay. As far as our gestational age, right? If it's a preterm newborn, we're going to have a lot more people at the bedside and a lot more care available for this newborn. If the baby is post dates, we're worried about a big baby, a macrosomic baby, so we're worried about a shoulder dystocia. Okay. Um, we are going to want to know risk factors. So, like you said, we're worried about if mom has gestational diabetes. Is she hypertensive? What other things has she been dealing with throughout this pregnancy? Is she a drug user? Do we have a run a risk of having a newborn who's going to be immediately going through withdrawal and not doing very well, with or facing some respiratory depression because mom used drugs right before she went into labor? So we need to know these things, right? Because that's going to prepare us for what to expect whenever baby is born. What is the amniotic fluid color or odor? Was mom bleeding excessively? That is one that is huge. If you have a mom that's been bleeding very heavily during labor, where we're suspecting that she may have been partially abrupting, is that baby also going to be fluid depleted? Yes. So that baby may need some IV fluid resuscitation and need an IV after delivery. Okay, so these are all some things that we need to take into consideration as the newborn nurse. Did baby have any weird heart rate abnormalities during labor? Was baby having reoccurring late decelerations? Was baby having really deep variables or repeated variable decelerations, right? These are all things that we're going to need to know. So here's our scenario as a baby nurse. We just received a report. Jill is a gestational diabetic and has had poor glycemic control. She's in induction of labor at 39 and 4 weeks of gestation. The membranes ruptured 4 hours ago and the fluid was mech stained and odorless. The fetal heart tracing has had a normal baseline, moderate variability, accelerations, and occasional variable decels. So before we move on to the next slide, what of this, as the newborn nurse, is standing out in your mind?
Diabetes.
Diabetes. Yes. What else?
Her labor status.
Meconium stained fluid.
Yeah, meconium stained fluid.
Poor glycemic control.
Yeah, so this patient not only is a gestational diabetic, but she has not been managing it during her pregnancy. That is important for us to know. What else do you guys see that is concerning?
Meconium stained fluid.
Yeah, we have our meconium stained fluid. We also have a history here of these occasional variable decels. Okay. So it's not like they're saying the baby's having a variable deceleration with every contraction or having a variable deceleration every 2 minutes. Nothing like that. But just knowing that there was some presence of some variable decelerations, excuse me, should get our brains turning and wonder what was going on in utero to cause the baby to have those D cells, right? Okay, baby Charlie, welcome, baby Charlie. He's delivered onto the maternal abdomen. What are we gonna do first? This baby is just born. He's on her belly. What do we do? Keep it simple.
His APGAR score? Like how he's doing?
Not yet, because when do we start an APGAR? We start APGARs at 1 minute. So Charlie is like 2 seconds. What do we do first?
We dry them off first.
Yeah, we're drying him off. We're gonna put a blanket on him. We're gonna dry and stimulate that baby. Okay? So that's the first thing that we're doing. We're not gonna get vital signs. We're not gonna be worrying too much about that yet. We're not doing an APGAR score. We are drying and stimulating that baby. Because our APGAR, like I said, it's not going to start until that first minute. And let me tell you, after being in hundreds of deliveries, that first minute goes by very slowly, especially if you have a baby who's not necessarily super pink crying and not doing awesome. That first minute can feel like 10 minutes. So, what we usually do is we hit an APGAR timer on the warmer, and then it'll give you an alarm for that 1 minute mark, and that's when you're going to get your first set of APGARs. Okay, but we're going to dry and stimulate that baby. You guys might see that question, so I just keep it simple, right? If the baby needs to be suctioned with a bulb suction, how do we do this? What's the order that we suction baby, like the baby's baby in? There's a specific order to it.
I don't know, but common sense is telling me you would squeeze the bulb outside of the mouth and then put it in and then release it so that you're not blowing anything down, but you're only pulling out.
Yeah, definitely. Yeah, that's exactly right. Do we suction the nose first or do we suction the mouth first?
Nose?
The mouth.
And
Sorry,
and
you were one of two, one of two.
It was a 50-50.
Yeah, you had a good shot, but nope, we're doing the mouth first. So, like you said, Christina, we squeeze that bulb first, we put it in the mouth, we release it to suck out any of that fluid or gunk that's in the mouth. Then we like squirt that usually on the side of the bed or somewhere out else. And
we
then we
have,
were gonna suction out the nose.
sorry, Professor. We have an acronym on in fire rescue. We say M, suction M before N.
What'd you say? Say that again.
To suction babies,
Mhm.
M, we use the acronym M before N, like the alphabet. You
Oh
go
yeah, that's
M
great.
N. So
I love that. Yeah, that's way easier to remember. M before N. Yes,
yeah.
we need to do our mouth and then our nose. I love that. Okay, so we already kind of talked about this. Our evaluation that's going to be done at 1 minute and 5 minutes of life is our APGAR. Okay. You do not necessarily need to get an APGAR score before that 1 minute, and then after 5 minutes, we're going to talk about. Okay. So if the score at 5 minutes is less than 7, when are we going to reassess that APGAR?
10 minutes.
Yes, we're going to do it every 5 minutes for up to 20 minutes. Okay. Um, So if we don't immediately have a reassuring APGAR, we do it that 5 minutes. If it's less than 7, we continue to do the 5 minute up to 20. Okay. If the score is between 5 and 7, what should the nurse do? This baby's not doing so hot, right? 5 is a pretty low APGAR if we're thinking about our graph and thinking about everything that we're assessing on this baby. So if we're thinking about that, what are we going to need to do probably if the APGAR is between 5 and 7?
We might have to oxygenate.
Yeah, we're going to oxygenate. So we're going to reposition the head to open the airway and provide gentle tactile stimulation. we also need to call the provider for help. So we're not necessarily like, at this time, we're not necessarily freaking out like we need to do PPV, we need to do chest compressions, like everybody panic. No, we're just going to try and do our little things that we can do to open the airway and ensure that the airway is patent. If we know that our baby like has meconium fluid and they're born from a gestational diabetic mom, should we probably have already had our provider at the bedside with us for delivery? Yes, for sure. Because this mom already has predisposed risk factors. This baby already has risk factors associated with mom's medical history. So we're probably going to need a provider to give us further orders and assess this baby immediately upon birth. Okay? Where is the best place for Charlie for thermal stability, cardiopulmonary stability, and bonding after birth?
Skin to
On the
skin.
mom's chest.
Yeah, skin to skin on mom's chest. That is where we want Charlie to be. Okay? It is shown that babies in the first like 24 hours of life do a little better if they are given that 1 hour of bonding skin to skin time. Okay? If your baby comes out and they have an APGAR score of 0, are we prioritizing skin to skin? No. Okay, and it does not really matter what mom's preferences are, what her birth plan says. If that baby's APGARs are less than 5 after that 5-minute mark, that baby's going to the warmer and getting resuscitated. Most of the time, it's before 5 minutes if it's looking like that. Okay, so here is our APGAR score. You guys are definitely going to need to know what each of these indicators are and what points are assigned with what response from the baby, okay, for your exam. You guys will need to know this. So let's practice. At 1 minute of life, the nurse assesses the following. Charlie has a vigorous cry. His heart rate is 122. He has blue or pale coloring throughout his whole body. He is moving extremities and he responds to stimulation. What would you give him for a 1 minute APGAR? So let's
8.
walk. Yeah, 8. Awesome. Yeah, let's walk through it together. So your baby has a vigorous cry. We go down here to our respiration and we see strong, vigorous cry. So that's a 2. Okay. Heart rate is 122 beats per minute. So we go to our pulse. And then anything over 100 is going to be assigned a 2. Blue or pale color throughout. We're going to go up here to our appearance and we see blue, cyanotic, pale all over. Okay. So that's going to give us a 0. Moving extremities. We go down here to activity, which is also our muscle tone, and we see active motion. And that is going to be a 2. And then response to stimulation. We go to our grimace or our reflex irritability, and it says prompt response, sneezing, crying, or pulling away when stimulated. That would be a 2. So we're taking 2 points off for our color, our appearance. Okay, so that would give us an 8. Is this an okay APGAR score at 1 minute? Yeah, this is just fine. Okay. We typically, when we're assigning APGARs, are going to remove points for color is the most common thing that we're taking points off of. Okay. At 5 minutes of life, the nurse notes the same findings, except the baby now has acrocyanosis and is centrally pink. So what would that APGAR score be then?
9.
Yep, 9. We're going to give a point back for color. When should we reassess the APGAR?
Five minutes.
So for this one, we actually won't need to because the score is over 7.
Oh, he's stable. Yeah.
Yeah, so that baby is technically stable. So at
M.
that point, then we're just going to assess the baby regularly, do our normal vitals and all that. However, if a baby were to like revert back, then we could potentially assign them a new APGAR, but we don't usually use APGARs outside of just immediately after delivery. We are going to skip this video. Okay, so what risk factors will the nurse consider when we're taking care of Charlie? So what things were we worried about with mom?
Blood sugar?
Yeah, we're worried about the baby's blood sugar. Yeah. Mom had gestational diabetes. So that baby is not going to be able to regulate their blood sugar as effectively as a baby born to a mother who does not have gestational diabetes. Okay. We're also worried because she had some neck stained fluid, which can lead to what?
Respiratory distress.
Respiratory distress, meconium aspiration syndrome. So, like we said, we're worried about hypoglycemia due to mom's gestational diabetes status. We're also worried about meconium aspiration syndrome due to meconium stained fluid with this baby. All right. So let's kind of talk through hypoglycemia in a newborn because this is really important for you guys to understand, especially for your exam and your HESI. You guys are going to definitely see this again. So with hypoglycemia, how is that baby going to present? Let's start with that.
Wouldn't that be hard to stimulate?
They might be a little lethargic. Yeah. Yeah. What else could a baby that has low blood sugar, what would they be doing or how would they present?
I'm not sure the medical term, but could they almost look like they're shivering, like a little bit of a tremble?
Yeah, we call it that the baby looks jittery, jitteriness. Yeah, that's exactly right. What's a normal, like, what do we not want our blood sugar to be under for a newborn?
You're 45?
It's 40. You're really close. Yeah, some hospitals are 45. For the purpose of the class, we say anything under 40 would be a hypoglycemic reading. So let's see. What would we see? We're going to see a blood sugar under 40. Baby will be jittery. If a baby has low blood sugar, they are not going to be able to regulate their temperature correctly, right? Because their body is trying very, very hard to maintain homeostasis, right? So if we have a baby who's hypoglycemic, their body is trying to compensate, use that brown fat to try and stabilize and metabolize for their blood sugar. Okay, so their body is not going to also be able to thermoregulate as effectively either. Okay, we also will see respiratory distress in these infants, and that's because with a hypoglycemic infant, we run the risk of metabolic acidosis, right? So, if we have metabolic acidosis, what can that ultimately lead us to? Respiratory acidosis. Okay, so with respiratory acidosis, we're going to start seeing the respiratory distress. We're going to see symptoms associated with difficulty in breathing, all of those things that we don't want to see in a newborn. Okay, but that all stems from that metabolic acidosis. That poor muscle tone and the lethargy are going to be associated with hypoglycemia as well. And if it gets bad enough, the baby can sometimes have seizures. Okay. What should we do in a baby that has low blood sugar? What do we want to do?
Encourage the mom to feed or to bottle feed.
Yeah, it's just like a little kid or an adult. If they have low blood sugar, we're going to give them something to raise their blood sugar. These babies typically, we need them to nurse every 1 to 2 hours. Moms are sometimes not thrilled about that because that includes waking up in the middle of the night to feed your baby every 1 to 2 hours. So we're first going to make sure that we're testing our blood sugar. There is a correct way to test the blood sugar for a baby. So we need to test before feeds, okay? Because we want to see what that glucose is doing without any sugar or without any nutrition in the belly, okay? We want to see if if they're able to regulate it on their own or not. We need to make sure that blood sugar should be above 40. This is done by a heel stick. We're drawing the blood via heel stick, and we use a glucometer just like you would in a med surg patient. And then those frequent feeds are going to be every hour to 2 hours. Okay. Any questions on this so far? You guys are doing great. We're almost there. Okay. Now let's talk about meconium aspiration syndrome, because with this baby, we're worried about hypoglycemia and we're worried about meconium aspiration. With a meconium aspiration, what are we going to see? Like, what is that baby and how are they going to present?
Like a
Cyano-
green.
Sorry, what was that?
Cyanotic retractions, belly breathing.
Yes. This baby's going to be in respiratory distress, right? So, tachypnea. So they're going to be breathing really fast. We're going to see that transient tachypnea in the newborn, that TTN, that transition period. However, it's going to last a little bit longer, most likely, in a meconium aspiration baby. They're going to be grunting. They're going to have nasal flaring, substernal intercostal retractions. They're going to be cyanotic, and sometimes with those seesaw respirations. And then occasionally they can have periods of apnea that last longer than 20 seconds. Okay. So these babies are going to be working really, really, really hard to breathe. Okay. What are we going to do besides provide respiratory support if this baby is having all these other things? What would our respiratory support look like?
Oxygen.
Yeah, we need to give them oxygen. So here's what we're going to do. We're going to call our provider. We're going to try and stimulate them to cry, because if they're crying, they're trying to get that fluid out. They're working that fluid up and out. We're going to try and suction. Okay. Sometimes with a meconium aspiration baby, using a bulb is not good enough. We have to use an actual like catheter and do what's called deep suction down and then pull out the catheter as we're suctioning out the baby's throat. This is something that you have to do very, very cautiously, obviously, because it's a newborn and everything is a little bit smaller and more fragile, but because we don't want to cut off their airway for too long, because these babies are already in distress. Okay. We're going to be administering potentially CPAP or PPV. We need to monitor their SpO2, and then this baby may require intubation. Um, so we may need to actually drop a tube and do the breathing for this baby for them. Let's see. I think this video shows you breathing problems that we can see.
Breathing problems in a young baby, especially rapid breathing and chest indrawing, are signs of a serious, often life-threatening condition. This video will show how to evaluate and treat the baby with a breathing problem. Before checking the baby, wash your hands and the thermometer. As you take the baby's temperature, gather important.
So you see on this baby, I want to pause that for a second.
When did the
Maybe. So you saw on that baby how like
This video will show
Here you can see like the retractions and that belly breathing, that really rapid breathing here.
how
That's what we're going to see on a newborn if they're in distress.
baby with a breathing problem.
I don't know if it shows any other examples. I don't think it does. So let's go.
Before check.
Okay, let's start talking about the newborn in the first 2 hours. So, one of the most important things that we need to do for these babies is ensure thermoregulation because, like we talked about before, or like you may have watched in my recorded PowerPoint this week, babies do not have great thermoregulative abilities yet. Okay, so we need to make sure that they're away from any drafts. We need to make sure that they're warm, that they have on appropriate amounts of clothing. This is really important also to educate specific patients on. So, like when I worked in Amish country, or I still work with the Amish, we have to tell them because they don't have air conditioning, they don't have heating, right? So we tell them whatever layer that you have on, you can add one more layer to the baby's clothing, but we don't want them to overheat, right? So in the summer, these babies like they don't need blankets. And I've had it before where they'll be like all bundled up in like winter gear, ready to go home to the no air conditioned house, and you're like, no, no, let's not do that. So we need to educate patients big time on thermoregulation for their infant. So that includes drying, removing any wet blankets, making sure any surface that the baby is on is warm, putting them skin to skin, making sure a hat is on because babies lose a lot of heat from their head, and swaddling the infant appropriately. Okay. In my PowerPoint, I go through like conduction, convection, the different ways that heat can be lost or transferred. You guys will need to know that for your exam. Okay. So make sure you guys are paying attention to that. Okay, I think we're out of time here. So we are going to pick up where we left off next week. So we'll finish out that PowerPoint. Get take some time tonight to do something for yourself. You guys worked really hard on your exam, and I know it's hard to lecture afterwards, but you all did a great job. And if you need anything at all before we meet next week, please reach out to me. I'm more than happy to meet with you or help you however I can. Okay? But I hope you guys have
Thank
a good
you.
night.
Thank you.
You're welcome.